Antenatal care. Our goals with this lecture is to list the assessment and physical exam involving the antepartum patient, manage minor disorders during pregnancy, and review health teaching. Prenatal health assessment, we do it to establish baseline of the mother's present health, determine gestational age of the fetus, monitor the fetal development and maternal well-being. We want to identify risks, and then we want to minimize the outcome of those risks, and also provide education regarding pregnancy, lactation, and newborn care. This box shows you the assessments that you would do for your healthy pregnant woman. Always remember, when you're dealing with pregnancy, you have two patients. So at each visit, we are assessing not just the mother, but also the fetus. Make sure you understand your terms related to pregnancy. For example, gravida refers to how many times a woman has been pregnant. Para would be how many times she's been pregnant to the point of viability, which usually means after 20 weeks. Premi is a prefix meaning first time, multi meaning multiple. So make sure you understand these terms. On our initial visit, what are our goals in providing antenatal care? Well, we do prenatal care for the point of reducing maternal mortality and morbidity rates, improve physical and mental health of women and children, identify and any potential adverse pregnancy outcomes, and to decrease financial recourses for care to mothers, which is basically saying prevention is the best. Antenatal care. What are factors that can affect a mother being able to get antenatal care? Well, location would be one. Socioeconomic, psychosocial, does she accept the pregnancy? What health services are actually available to her, and environmental factors. So when we have our initial visit with our prenatal client, we want to establish a trusting relationship and establish a rapport. This is important because she's not going to divulge anything that such as maybe abuse of drugs or alcohol if she doesn't trust you. So it's very important that you develop that relationship. And trust factor. We also want to get information about her present physical and psychological health, and obtain, based on that, what we're going to provide in anticipatory guidance. During the first visit, we're going to find out her medical history, a full head-to-toe physical exam, get some labs, assess her psychosocial well-being, and also a nutritional assessment. So we get her personal and social history, including her any type of cultural concerns, her marital status, her occupation, because there may be hazards within her that she'll be exposed to in her occupation. We also have to establish an approximate gestational age of the fetus, so we need to know when her last menstrual period was, her age of menarche, how regular her menstrual cycle is, because that might affect the dating of the fetus or how old the gestational age is, the contraception method that was used, especially if she's using birth control pills, because estrogen is category X. We can have some teratogenic effects, so we want to know exactly what type of contraception she was on, if she was on contraception, and if she's had any previous treatment of menstrual disorders. Nagel's rule, so we want to estimate her date of delivery, and we do Nagel's rule means that we find out the first day of her last menstrual period, take away 3 months, add 7 days, and change the year if necessary. And if she told us her last menstrual period, the first day was August 30th, 2007. Let's take away 3 months, and that puts us in May 30th, and let's add 7 days. That brings us up to June 6th, and we know 9 months later from June 6th would run into the next year, so her due date would be June 6, 2008. We find out if there's any current problems we need to help her with during this present pregnancy. Nausea and vomiting comes early. If she has any abdominal pain, because we'd be concerned if she's having an ectopic pregnancy. Headache. If she comes late for prenatal care, headache might be a sign of preeclampsia. Urinary complaints, only because UTIs is a risk factor for preterm labor. So if she's having any type of urinary pain, then we need to address it. Vaginal bleeding, of course, that could be, does she have a threatened miscarriage, edema, backache, heartburn, or constipation? And we'll go over those in detail later in this lecture. Exhaustion, nausea, sore breasts, and other symptoms are very common. In fact, tenderness and tingling to the breasts usually is a complaint before she even knows she's pregnant or she has a missed period. We want to find out her OB history, what happened in her previous pregnancies. It might tell us about any potential problems. For example, if she's had nothing but C-sections, she may not be a candidate for vaginal delivery. We want to find out how many times she's been pregnant, how many were past 20 weeks, did she have any abortions, and how many living children there are. Weight of infant, that is important because one of the risk factors in gestational diabetes is a woman who has a history of large infants. That might be a signal that she's at risk for gestational diabetes. And also to find out if her pelvic could accommodate a large infant. That would impact if we're going to do a vaginal delivery. What type of a labor experience did she have? Does she have a history of having very long labors or very fast labors? And did we have any maternal or infant complications? Did she have pregnancy-induced hypertension in a past pregnancy? Was the infant preterm? GTPAL, you must understand this. You may be asked this at boards, you may be tested on it, you may see it on the HESI. GTPAL, gravida, means the number of times she's been pregnant. Term is how many births went to term after 37 weeks, how many premature births, how many abortions, that could be spontaneous or elective, so that would be anything before 20 weeks, and now refers to current living children. Remember that multiple births, if she had twin or triplets, count as one birthing experience. So let's look at some examples. A 23-year-old currently pregnant at 35 weeks has had one miscarriage of twins at 16 weeks and one abortion. So she's presently pregnant. She was pregnant with a miscarriage of twins and one abortion. So she's been pregnant 3 times. So that's gravida 3. None of them went past 20 weeks. None of them, so term and preterm would be 0. She had that miscarriage of twins, but it counts as one experience. And then she had the abortion. Those are 2 events before 20 weeks. So A is 2, and none of them are living. So her GTPAL is 30020. 32-year-old, currently 23 weeks pregnant, comes to the prenatal clinic. She has 3 children. One was born at 30 weeks and survived, so that's a preterm. And we have 2 full term. She had 1 stillbirth at 35, that's preterm, and 1 ectopic pregnancy that was surgically removed. So she's presently pregnant, counts as 1. She has the 3 children, so that brings us up to 4. She had the stillbirth, which brings her up to 5, and the ectopic pregnancy brings her up to 6. So gravida 6. In the background here, she had 2 that are full term and living, so that's T2. The stillbirth was at preterm, and 1 was born at 30, so preterm is 2. Abortion, she had 1 ectopic, and presently she has 3 children living, so that it's 62213. We have a 44-year-old currently 16 weeks pregnant, 3 children living, 2 preterm and 1 term, 2 separate spontaneous abortions, and another child born at term and died 3 years of age. So she's presently pregnant. She has 3 children, brings her up to 4. She has 2 separate spontaneous abortions, that brings her up to 6. And she did have another child that was at term that died, and that brings her up to 7. So she is gravid at 7. She had that one that died at term, that's 1. And then of the 3 children, that one of them is term, so term is 2, preterm 2. She had 2 spontaneous abortions, so abortion is 2, and presently she has 3 living children. So medical and surgical history, of course, something such as diabetes or hypertension, those chronic conditions can impact the growth and the nourishment of the placenta, and the mother's well-being. So of course that's important. Renal disease can affect the outcome of pregnancy. We got to know if she has any prior operations, particularly related to the cervix and the uterus, because that could impact her ability to again have a vaginal delivery. Any allergies, medications also, because there's several medications that are teratogenic, so we need to document them. And some of those medications are for chronic conditions such as seizures. Cervical cerclage, that's when we sew the cervix. If she has a history of having very early preterm labor, that would be under 20 weeks, then a lot of times what they'll do is they'll stitch it up early and then cut the stitch when she gets near term, so we need to know if she has a history of that. And if she's had any accidents involving injury to the bony pelvis. These are medications that might be a problem if she has a history, and again, her psychosocial assessment of being bipolar. Lithium is classified, I think it's D. Anti-seizure medications, a lot of them are classified D. NSAIDs, we don't want to take in the 3rd trimester. Accutane for acne. Misoprostol is category X, and if you're interested in reading about meds that are contraindicated in pregnancy, here's a web link for you to go to. And also remember, there's some medications that are not safe in certain trimesters. We want to know her family history. That can give us valuable information. If we find out maybe in the history their grandmother had delivered a baby with congenital anomalies, she may be a candidate for genetic testing by amniocentesis, because there may be something that's hereditary. So we can find out if there's any patterns of that, and that would include knowing if there's a family history of diabetes, hypertension, heart disease, cancer, and anemia. Physical exam, again, remember we're going head to toe. And a lot of times in a physical exam, this is the first time since maybe going to a pediatrician, a woman actually comes to see a provider. So we may find in our assessment that she has something going on, or we discover something. Remember, we can see a lot just watching the woman walk in, as far as her gait, her coloring, pallor, maybe she's anemic. We can observe for any type of edema, or her eyes jaundiced. It's important to get baseline vital signs, because that will be the measure when we run into complications, potential complications later in pregnancy, such as preeclampsia or pregnancy-induced hypertension. Also, the thyroid expands during pregnancy to accommodate the fetus. So we want to see if we're going to pick up on maybe her having possibly hypertension. I mean, not hypertension, hyperthyroidism. And we can see that by the pulse. The pulse would be tachycardic. Respiratory rate and temperature. Height and weight, again, that's important because we're going to make sure she is gaining adequate weight through the pregnancy. And also, if she suddenly starts putting on some edema, like in preeclampsia, we will see a sudden weight gain. Also, the provider will check the pelvis to see if it can accommodate a full-term fetus. Now, these are the 4 types of pelvises that we can have. The gynecoid is the one that is ideal. It allows for rotation of the head through the pelvis as well as the shoulders. And it's easy to remember that's the ideal because gynecoid, just think of gynecology. And of course, the android, which is more of a heart-shaped, is actually the shape that men have, the male-shaped pelvis, and androids such as androgen. And again, it's to accommodate the fetal head and shoulders to rotate through. Also, we assess the breasts. In early pregnancy, we'll start to see that the areola enlarge, and through our additional assessments, you should see that it starts to darken. We also do our baseline lab data. A blood group is important because if she is Rh negative, she'll get RhoGAM for any type of injury. If there's a potential mixing of blood, of fetal maternal blood, if she has any type of bleeding incident. H&H to detect anemia, which is not uncommon that she would develop that in pregnancy, and of course they would go on iron. We screen for STDs. Syphilis is a concern because that can cause congenital anomalies, and the other ones such as chlamydia and gonorrhea, we do that through a smear. We take vaginal secretions and do a smear and look at it under the microscope. The reason we check for that also is because STDs are a risk factor for preterm labor. We went over urine analysis. We're worried about UTIs, and in fact, UTIs is if they're pregnant, is the one time we treat a woman who is asymptomatic. If you're not pregnant and they find a little bit of bacteria in your urine and you don't have no symptoms such as urine frequency, they don't treat you with antibiotics because you're just colonized. But in pregnancy, we always treat even if they're asymptomatic because it's a risk factor for preterm labor. Rubella and varicella, a lot of viruses can cause severe teratogenic effects. We get those vaccines now, at least. Most people have been exposed, if you didn't get the vaccine, to chickenpox in their childhood. And we check the titer to make sure you have immunity to it. Because if not, then we're going to provide instructions that you should avoid being around people who have chickenpox. Now, the rubella, we would not give the vaccine. In fact, if someone plans to get pregnant, we tell them they cannot get pregnant for 1 month after receiving any type of MMR booster, measles, mumps, rubella, because of the rubella. We do a pap smear to screen for cervical cancer, and if it comes out that she has some dysplasia, we'll rescreen after she delivers the baby. We check the hepatitis B, and again, we can do another test for screening for syphilis. Managing the minor disorders of pregnancy. Commonly, they'll complain of urinary frequency, and that's because of the pressure of the uterus on the bladder. That's in the first trimester and the last trimester. As we go into the second trimester, the baby starts to grow and come out of the pelvis. So there's pressure taken off the bladder, but then when the baby lightens, known as dropping, and drops, then they are prone again to having urinary frequency because of the weight of the bladder or the baby on the bladder. Nausea and vomiting, that's related to the HCG. That's the hormone, again, that helps keep the corpus luteum thriving for the first few weeks until the placenta can create its own estrogen and placenta. estrogen and progesterone to support the pregnancy. And we tell them to manage the nausea and vomiting by eating small, frequent meals, eating foods that are bland, such as toast. Don't eat spicy foods. However, if the vomiting gets to the point of where she can't keep anything down and she develops dehydration and electrolyte imbalance, that's known as hyperemesis gravidarum. That will be reviewed in pregnancy complications, and she would have to be hospitalized for that. Patient teaching in the first trimester. First, we tell them you are not eating for 2. You need just 300 extra calories a day. No alcohol or smoking. Many years ago, they used to say you can have, 1 or 2 drinks. You can have a limit on cigarettes, but now there is none because of fetal alcohol syndrome and the effects of smoking on vasoconstriction as far as the uterus is concerned. Also, prenatal vitamins, particularly folic acid, B6, that is important to prevent neural tube defects. Remember, that's part of education before they even become pregnant. If they plan to get pregnant, we tell them start taking B6 now. And based on the labs, if they're anemic, they may have to go on iron. In fact, again, that's quite common. Also, we tell them if they get any type of prescription drugs, always notify your obstetric provider. And also, don't take anything over the counter till you clear it with them. We also review any type of skin changes they might see, and when they should call the obstetric provider, such as with vaginal bleeding, again with hyperemesis gravidarum, that means excessive vomiting, that they can't keep absolutely any food down. At the website that this course is, please make sure you print off the prenatal care handouts that are there. It's 2 sheets showing exactly at what weeks all our fetal assessment tests are done, and also your first trimester teaching handouts that reviews everything that should be reviewed with the woman. Trimesters are divided: first 0 to 13, second 14 to 26, third 27 to 40. So we schedule monthly visits up to 28 weeks. Then we go every 2 weeks until 36 weeks, and then afterwards we go weekly until she delivers. However, if a complication arises or if she's a high-risk pregnancy, we may see her more frequently. So as she comes for each of those visits after our initial visit, we inquire about any physical changes that she's going through. Does she have any type of illness? Did she receive any new medications from another provider, such as in an emergency room visit, or her primary care provider? Also, in our assessment of the fetus, we would again check up on fetal movement, listen to the fetal heart rate, make sure the fetus is also doing well, because remember, we have 2 patients. So first we look at the abdomen. First thing we do is, again, you look at it, you inspect it, and we look to see if we see some of those changes that are expected with the skin. That would include the linea nigra, striae gravidarum, which is known as stretch marks, if there's any scars. We're also looking for height of the fundus. Does it look by inspection very large for how many weeks gestation she's supposed to be? And these are the skin changes we might see. Linea nigra, again, it's a line that goes down the abdomen. Stretch marks. And also with the face, when she walks in, is she having chloasma, which is called the mask of pregnancy. We also check the fetal lying position. Is the fetus lying longitudinal? A breech or head first delivery will be up and down, and that's longitudinal. Vertical lie is very rare. That's known as a shoulder presentation. We also check for fetal movement. Do we see the baby or the I'm telling you, in the last few weeks, I know from being a labor and delivery nurse, you can just look at the stomach, you can see the baby's arm or shoulder move across the stomach. Fetal heart rate is another thing that we're going to look at. You can actually hear it with a stethoscope after 20 weeks, but until then you can pick up on it with a Doppler. Starting with the 8th week, and normal range would be, in early pregnancy, it would be higher, 120 to 160, but once she starts getting past 30 weeks, the normal range is 110 to 160. Contour of the abdomen wall. Next, after inspecting, auscultating, and that would be for the fetus, then we can do palpation. And with palpation, we're estimating the period of gestation. What we do is we measure from the symphysis pubis up to the top of the fundus, and that gives us an approximation of gestational age. What it is that how many centimeters high you are. We expect that the fetus is approximately plus or 2 centimeters. So if 20 weeks, we expect the fundus to be at the umbilicus, and if you measure that high, which is about 20 weeks, that fetus may actually be between 18 and 22 weeks. Now with the new technology, and we do ultrasounds for early dating, really the purpose of this is to make sure that the baby's growing steadily, more than using it as a measurement of gestational age. And that's where approximately the height we expect to see based on how far along she is in her pregnancy. So at 12 weeks, we should just be able to see the top of the fundus, feel it right outside the symphysis pubis. 16 weeks, it will be halfway between the umbilicus and the symphysis pubis. 20 weeks is a landmark. And then it keeps going up. Once you get past 32 weeks, it's less reliable as a measurement. And then when they get to 36 weeks, especially in a first-time mom, the baby may drop and lighten. So then at 40 weeks, the height is a little bit less. Now suppose you're taking care of a mother and we measure it, and it seems really out of measurement for how many weeks she is. Well, if it's significantly higher than expected, it may be that she has a large fetus or a multiple pregnancy. She may have too much amniotic fluid, or maybe there was a mistaking in her dating for her due date. If it's lower than expected, maybe we have a small fetus due to intrauterine growth restriction, and that would be that the placenta is not being nourished well, so the baby is not thriving in there, so it's not doing well. And remember, the placenta helps make also amniotic fluid. So if that placenta is not being nourished, then also we may not have very good, we would have low amniotic fluid, and that's the term known as oligohydramnios. Polyhydramnios means too much amniotic fluid, or maybe we mistaken her date of her last menstrual period. Causes of polyhydramnios: maternal diabetes, multiple gestation, pulmonary abnormalities. Remember, with amniotic fluid, the baby breathes that in and it excretes it through its kidneys. So if there's a problem with pulmonary, then it's not cycling the amniotic fluid, so we tend to have too much. Now, if there is a problem with renal, then we don't have enough because it's not excreting it out. It's not processing it. Also, if we have any type of leak or tear in the bag that may not be obvious to the mom, a slow leak, we may have low amniotic fluid, and we know that as any type of rupture of membranes, ROM. And also, again, if the placenta is not doing well, it's being insufficient, it's not making the amniotic fluid, that also could be an underlying cause. Twin-to-twin transfusion is another way that can be impacted by the amount of amniotic fluid. Twin-to-twin transfusion is when we have an unbalance of blood flow between twins that share a common placenta. So one twin will thrive and one will have intrauterine growth restriction because it's not being nourished. We also look at posture and gait. If she starts complaining of back pain, this is something that will happen possibly in the second trimester. We explain to them about good body mechanics, and that includes how well she sits with shoulders erect, because she can start developing with her center of gravity being off, a sway back, and complain of back pain. We look at with cardiovascular venous congestion. Remember, in pregnancy, by the time they get into the second trimester they are carrying 50% more blood volume, so they can start developing some venous congestion. And that congestion not only goes into having swollen ankles, but also the development of hemorrhoids from rectal congestion. Edema, if it's very generalized with the face and hands, she's saying the rings aren't fitting well, then we got to worry that maybe she's developing preeclampsia. Deep tendon reflexes should also be evaluated when they have preeclampsia. Again, we'll go over details of that in pregnancy complications. The cerebroedema can cause pressure on the central nervous system, and they start getting hyperreflexia with their deep tendon reflexes. And now we're just going to review deep tendon reflexes. Now in this video we see this one is hyperreflexic. This one's normal, it's about a +2. And this is how we check also for clonus. Clonus is hyperreflexia, which is very severe, and we're looking at tapping of the foot. Now see how that foot's tapping down? If you have a patient with severe preeclampsia, we actually document clonus and then how many taps we got with the tonus, as you saw with that foot tapping down in that video. Also with palpation, especially in the last month, we want to know how that fetal lie is in the last couple months. And we're trying to find out if the baby's breech or not. And that's important because if we're still earlier in the third trimester, we may do a procedure where we actually move the baby from going breech from the outside. We maneuver it to go into a head first position. So here we are feeling the top to see if it's a round head or pointy sacrum. That's maneuver 1. In maneuver 2, we're checking where the feet and hands are. In the third maneuver, we're checking if it's head first. Actually, what we're doing is we're verifying whatever we felt in A, we're verifying in C. So if we felt the sacrum or the buttocks in A, then we're verifying that we feel the head in the pelvis. Then we're feeling for what we call the attitude. We're checking if the forehead is on the same side as the hands and feet. That's called attitude. That's how well the baby is flexed. And that's important because if that baby does not have a good attitude and we actually feel the back of the head on the same side as the back, and we don't feel the forehead on the same side as the arms, then that is more of a forehead presentation. And or face presentation, and that does not mold as well, and it has a larger diameter than delivering occiput, which is the back of the head here. And that could result in dysfunctional labor. Okay, again, legs in general. Is she having any swelling or pain to the calf? Remember that in pregnancy they have a lot of that fibrin. They have hypercoagulability because that's the baby's way, the body's way, the woman's body's way, that when after she delivers in postpartum, delivers the baby, for the body being able to heal itself afterwards. So she carries a lot of fibrin, but that puts her at risk then of developing blood clots. So we got to check. She's at risk for DVT, and that's another reason why we tell women, especially in their last month of pregnancy, if they're going to be doing a lot of traveling, make sure they get out of the car, walk every 2 hours if they're doing a lot of driving, and also to be careful about crossing their legs. Any type of vaginal discharge, they should have an increase in the end, but if they have any type of foul-smelling discharge, we got to, again, investigate. Does she have some type of STD? And also, as far as instructions with that also, since we're talking about vaginal discharge, we absolutely tell them no douching. We don't want to upset the natural flora during pregnancy because the pH during pregnancy, normally, if we're not pregnant, our pH is pretty neutral, about a 7, but during pregnancy it becomes more acidic, and that's the body's way of protecting itself from any type of bacteria migrating up and causing potentially an infection and a risk factor for preterm labor. We tell them if they have any type of vaginal discharge, it needs to be reported and investigated. Also, on the H&H, if she is anemic, we'll retest it at 36 weeks. And if she's very low, less than 9, every 4 weeks, we're going to recheck her H&H. And we review danger signs at each visit that requires immediate attention. So, what's reinforced throughout pregnancy? Dental care. Peritonitis is a risk factor for preterm labor. I want to stress that. In fact, that's why Medicaid covers dental care during pregnancy. If someone's on Medicaid for prenatal care, is for that reason. They want to make sure that they're not at risk for preterm labor related to caries and peritonitis. We talk about hygiene. They should avoid any type of hot baths with vasodilation and the baby pressing on the vena cava. Remember, we went over supine hypotension. If we did not, that is when the baby, or you did not get to that lecture yet, it's when the baby presses on the vena cava, the weight of the baby, then it slows down circulation to the lower extremities and bringing blood flow back. That's why they recommend that women sleep on their side instead of on their back. And by that, it causes, with the lack of blood flow back up, she's at risk for fainting. And, sitting in hot water contributes to that. Plus, you're raising your core temperature for the baby also. In fact, that's what you're doing. But because of that vasodilation, the pregnant woman's at risk for fainting for that reason. And again, what I discussed about vaginal douches should be avoided except for excessive secretion or infection. So what they're saying with that is that vaginal douching, unless it's prescribed, such as one for maybe a yeast infection, they should not be douching routinely in hygiene. So, in fact, we'll just take that out. Danger signs in pregnancy, vaginal bleeding, including spotting, especially in early pregnancy, because we're worried about ectopic pregnancy. Vaginal bleeding later might be sign of an impending preterm labor. Could be placenta previa. It could be placenta abruptio, and those are all discussed in pregnancy complications, another lecture. Persistent abdominal pain, severe and persistent vomiting, we went over that. It could result in electrolyte imbalance. Sudden gush of fluid from the vagina, which means her membranes have ruptured, and our concern with that is a prolapse cord. So if there's pressure on the cord, there is no blood flow from that cord to the fetus. And we'll go over details of that in our fetal assessment lecture. Absence or decreased fetal movement. Severe headache is a sign of severe preeclampsia, edema, preeclampsia, any type of fever. We got to address it if she has any type of infection. Dizziness, blurred vision, double vision. Again, that is some of the things you see in someone who has severe hypertension. And any type of painful urination, because we want to treat that UTI. Again, breast care, her breasts are going to enlarge and get heavy, so we want to make sure she wears a good supporting bra. Dressing, they should avoid wearing tight clothes that might possibly restrict. Also wear shoes that are low. Avoid high heels. Sexual intercourse, unless there's a reason that's contraindicated, sexual intercourse is allowed and safe, except if she has any type of vaginal bleeding or ruptured membranes. Exercise, exercising, usually they say as long as she's doing what she's always done in exercise, it's safe. Except, as you get later into pregnancy, excessive bouncing and such. But it's not the best time to start maybe a new sport. She should remember to maintain adequate fluid intake, warm up, exercise on a regular basis, and to be careful of exercises where she's lying on her back, again related to that supine hypotension syndrome. Okay, so some contraindications possibly with exercise would be if she has an existing disease, severe anemia, because exercise is going to require oxygen consumption from her blood to the tissue, and that would take away nourishment to the placenta and the baby. Sleep, again, with sleeping, it's important that she has adequate sleep, and it's best maybe on her side. We want to avoid the baby, again, lying on her back to avoid that supine hypotension syndrome. Hazards, we review hazards, again, occupational hazards based on her occupation, infections, toxoplasmosis, again, we tell her don't change the kitty litter. Smoking and alcohol, avoid, and then there's certain drugs that she should not be taking. And in fact, with antibiotics, there's some antibiotics that are not safe in certain times of pregnancy based on the trimester. And anticoagulants, if she's on an anticoagulant, maybe she has an existing cardiac disease, Coumadin passes over into the placenta, so Coumadin should not be taken during pregnancy, but heparin is a very large molecule. Usually if they need an anticoagulant, they will switch them from Coumadin to heparin. Immunization, one of the new things that they added recently is that we now give Tdap at approximately 27 to 36 weeks. That's a routine immunization because of the tetanus for protection. But there are certain vaccines they should avoid, and they're the ones that are what we call weakened viruses. They're not dead, but they're weakened. And viruses are very small. They can easily pass over into the from maternal to fetal circulation. That would be our HPV virus, our chickenpox, vaccine, our HPV vaccine, chickenpox vaccine, our MMR, and the flu vaccine. They can have the killed vaccine by injection, but they cannot have the nasal one, that is the weakened one. But remember, when someone gets the injectable one, it takes a couple weeks to actually bring up the immunity. So it takes longer than the one that is weakened. And that's one of the differences between the flu vaccines, the injection versus the nasal. One, you get your, with the one that you do nasally, you actually develop your immunity faster. Diet, again, daily requirements about 2,500. We want to have a good balanced diet. We stress that. And again, that's about 300 calories a day. However, if she goes into breastfeeding, that's going to be even more once she delivers. Okay, women, if they're a normal BMI, the average weight gain should be 25 to 35 pounds. It will be higher if she's carrying multiple gestations. If she's underweight, she should gain more. If she's overweight, it's a little less. However, this is not the time to diet. What are some of our minor disorders during the second and third trimester? Well, one is heartburn. What happens is the hormones relaxes that cardiac sphincter, or actually the sphincter that goes into the stomach, the pyloric sphincter, and it allows for some of the GI contents to spill out. In fact, that's what happens with GERD, is that sphincter, the pressure is very relaxed. And plus now you have this growing abdomen pressing up on the diaphragm. So as they get on later in pregnancy, they may develop some heartburn. So same thing you tell your GERD patients: eat small, frequent meals, stay up at least 30 minutes after eating. They can take over-the-counter antacids like calcium carbonate, but they should not be taking something such as H2 antagonists or proton pump inhibitors such as Zantac without clearing it with their OB provider. H2 antagonists, some of them are class Bs, and your proton pump inhibitors, a lot of them are class C drugs. So if for any reason the heartburn gets really bad, usually they'll go to the H2 antagonist first, such as ranitidine, before they go on to your proton pump inhibitors. Backache, we went over about maintaining good posture. They may, again, from all the congestion, they may wind up getting some varicose veins through the pregnancy. Tell them to elevate their legs if they notice they're getting some edema to the lower extremities, just like we tell our CHF patients. Constipation, motility is decreased because of the progesterone, and then iron can be constipating, so make sure they have enough fluids and fiber. Exercise, walking, promotes peristalsis. They should not be taking laxatives unless they're prescribed by the physician, and usually that will be Coley's. Round ligament pain, we see that a lot with our first-time pregnancies. The round ligaments is what's attached to the uterus, and they stretch with the fetal growth. And I get them in a lot of times because they think they're in early labor, or they might be in labor because they have this pain in the lower abdomen. And usually what we'll do is we'll rule out a UTI, but it's commonly round ligament pain is what it is. They do sell these pregnancy support belts that might be of some help to them. Make sure in your second trimester we have to explain to them signs of preterm labor and when they need to call the provider. I do have second and third trimester teaching handouts at the website, so make sure you print them and review them. Also, we start teaching kick counts. One of the best measures of fetal well-being is kick counts, or that the baby's moving. That's a sign of fetal well-being. So we teach them how to count the fetal movements, and if they don't get any fetal movement, or the fetal movement is becoming less and less each day, they do need to be seen. We also review true versus false labor. True labor is consistent. False labor, and false labor is a lot of times from Braxton Hicks. Those are the false labor contractions. That's actually the uterus practicing for labor when labor actually kicks in. And usually if they walk and the contractions get less or go away, then we know it's false labor. We start reviewing breastfeeding because they have to prepare their breasts for breastfeeding. That would be like with bathing. And don't go using hot water and harsh soaps on the breast and the areola. Teaching them how to toughen up their nipples for breastfeeding. And when they should be calling the provider. And that's it. That's it for this lecture.